So, hello everybody, good morning, Kalimera. It's a pleasure to be invited to this very interesting meeting. Unfortunately, I cannot be in person with you in Kalkidike. I would love to be, but it's not possible this year. So thanks, Vasilios, for inviting me again. And the topic which has been assigned to me was to talk a little bit about the patient with obesity, pre-diabetes, and increased arterial stiffness. And I hope you will find it a little bit interesting. I will focus on some novelties maybe during the kind of discussion. So some considerations I will give to you. But first, let's start with the patient. We met this patient roughly 20 years ago. Now he's 43. He's a smoker. We met him 20 years ago. At that time, he was hospitalized due to syncope. His blood pressure was really high. He was not on antihypertensive drugs. And high blood pressure was confirmed by ABPM. At that time, not much about end organ damage, but retinopathy was excluded. Lab was okay. And enalapril at that time was started. 1 year later, again, he had kind of pre-syncope. He's an obese patient. He's 177 centimeters long, but 129 kilograms. So his BMI really is high. He was still hypertensive at that time. Secondary hypertension was excluded. And again, here now carvedilol was started because the patient was off meds when he came to the hospital. Now, 20 years later, there was one coronary CT showing minimal calcifications, which is now 6 years ago. 4 years ago, he was hospitalized in the psychosomatic department due to binge eating. You can easily imagine obesity, hypertension, smoking, again with ABPM, high blood pressure. Weight reduction was successful. The patient lost more than 10 kilograms within these 6 weeks, and he was discharged on amlodipine and ramipril. Now the patient was, that's in the presence, the patient was admitted again due to atypical chest pain. He's still obese with now 105 kilograms, which means he maintained the weight reduction 6 years earlier, waist circumference 109, otherwise normal. Blood pressure again was high, and he still didn't take any medication. That's the ECG, basically more or less normal. No left ventricular hypertrophy based on Sokolov or Cornell index. But of course, with obesity, one must be a little bit cautious in excluding LVH based on ECG. That's his biochemistry: cholesterol 190, LDL 141, triglycerides not that bad, uric acid elevated, renal function was normal, liver enzymes were normal, fasting glucose 121, so not normal, HbA1c 5.9%, which is already in a gray zone, of course. Again, ABPM was performed, and again, the patient was hypertensive. You see the 24-hour average of 153/90. We also measured arterial stiffness now by carotid femoral pulse wave velocity here with the Sphygmocore device. And as you can see easily, his pulse wave velocity was 10.4 meters per second with relatively high quality recordings. And you see here, based on population-based mean values, this is of course elevated. That's his echocardiogram. That's the parasternal view and the apical four-chamber view, of course. So you see the ejection fraction is well preserved, and the patient, of course, has left ventricular hypertrophy, which is not really a surprise. Valvular function was normal, right ventricle were normal. And due to the chest pain the patient had, we also did a CT coronary angio, and you see several calcifications here in the LED, which was one of the reasons why we did then in the end indeed perform invasive coronary angiogram. Well, I should have said that I'm working on an invasive cardiology department. So, and you see indeed there's some plaque formation here in the proximal LED. So it's at an age of 43, this is for sure premature atherosclerosis. So, which diagnosis could we establish? the patient has angina without obstructive coronary artery disease, but of course he has premature coronary atherosclerosis. He has primary hypertension, secondary causes have been excluded, hypertensive heart disease, left ventricular hypertrophy, for sure increased arterial stiffness, metabolic syndrome, elevated fasting glucose, he's still smoking, and has some hyperlipidemia. So then maybe I can share with you some consideration on the patient. First, to start with the thing which is the topic I have been given, so that's the increase in arterial stiffness. So the gold standard for measuring arterial stiffness probably is invasive aortic pulse wave velocity, and because here travel time and travel distance are exactly matched. These are original tracings from our cath lab, and it can be measured invasively very easily. So you see here pressure tracing from the ascending aorta and the pressure tracing from the bifurcation. And if you use the ECG for gating, you can easily calculate. You can even see the travel time, but you can easily calculate it. And if you put a mark on the catheter and you pull it out, you can easily measure travel distance. And if you put those two into a relationship, of course, you get a velocity, and that's a true aortic pulse wave velocity. But of course, you cannot do this in everyone. That's an invasive measurement. So the non-invasive gold standard here is carotid femoral pulse wave velocity. And on the right side, you see a younger version of mine here in our lab performing this kind of measurement here. That's with the tonometer at the carotid artery. You probably have seen this before. So you need a tonometer, for example, to record these pressure waves here at the carotid artery and at the femoral artery. And this is how it looks. You have seen this before. You have the pressure tracings here with a tonometer at the carotid site, see here, and here at the femoral site. And you again have the R waves of the ECG for gating. And if you put this into the system, and if you measure travel distance on body surface, you get pulse wave velocity here. And this would be a normal example, of course. Well, in some cultures, exposure of the groin, for instance, is not a good thing, or is not thought to be possible. And also, it's maybe a little bit easier to just put cuffs at the arm where you normally measure your blood pressure, and here at the legs. And as you see here, there's a time lag between the occurrence of the pressure curve here at the cuff, at the arm, and at the leg, and you can measure this. And if you then put this into relationship with body height, you get another pulse wave velocity, which is brachial ankle pulse wave velocity. It's more popular in Asian countries as compared to Europe, but still it's something to consider if you wish to start measuring arterial stiffness. And this is a nice summary here in a recent review article from in the JACC on possibilities to measure these pulse wave velocities. That's what we did with carotid and femoral pulse wave velocity using tonometers. You see the tracings here. You see the commercially available systems here. You could theoretically do this with any ultrasound machine as well. You can also use a cuff at the leg, or you can use two cuffs, and then you get a brachial ankle pulse wave velocity. And again, you see some of the systems which are on the market. Well, if you think, well, I'm interested in that, but it seems to be a little bit complicated. We have developed an estimate. You can also record with a cuff, but it's an estimate mainly based on age and systolic blood pressure. And you see here that's a kind of validation study in our lab, more than 900 patients. And in red, you see the invasive pulse wave velocities, they increase with increasing age. But here in blue, you see the estimate, and you see that at least for groups, it works very well. It nicely follows the invasive aortic pulse wave velocity. In green and olive green, here you see the carotid femoral pulse wave velocities, which show more or less the same thing. That's another cuff. They do more kind of a measurement, but it's debated if it's the aorta or the brachial artery, but they measure pulse wave velocities. And again, that's the validation study here. So it's that even simpler. So then what's the relationship between arterial stiffness and angina, with or without the obstructive coronary artery disease? Well, let's go back to the cardiovascular continuum. That's our usual thinking. That you have risk factors, lipids, blood pressure, diabetes, etc., the metabolic syndrome, if you like. Then you get plaque, atherosclerosis, coronary artery disease, ischemia, maybe an infarction, left ventricular remodeling, congestive heart failure, etc. This is well known now. That's his textbook knowledge, and that's atherosclerosis. And that's how it looks, or how it can look. High-grade stenosis here in the proximal LED. You put in a stent, and of course you need a lot of drugs to treat this patient. But there's another side of the coin, and this really starts here with aging and the fracture of aortic elastic lamella, aortic stiffening, etc., wave reflection, hypertrophy. This may lead to ischemia, and I'll show you later on how it can lead to heart failure, and it's also detrimental in the end. And that's arteriosclerosis, or in the end, that's arterial stiffness, so stiffening. And that's how it looks when we measure it. You saw this picture before. So, but in individual patients, but it also in groups of patients and in clinical studies, both processes actually work together for the detriment of our patient. And we need probably to touch both of them if we wish to treat them. And that's one of the physiological relationships between both two. And if you think about coronary perfusion, you know that this depends really on diastolic blood pressure, which is the driving pressure, but it depends even more on aortic stiffness. And there's a clear relationship here. This was an invasive study in patients following an invasive coronary intervention, following stenting, elective stenting. So there was no stenosis anymore. When the investigators measured hyperemic coronary blood flow, so the amount of blood flow running through your coronaries, and there's a clear inverse negative relationship, an inverse relationship between pulse wave velocity, so aortic stiffness, and hyperemic, also resting, but even more hyperemic coronary blood flow, which means the stiffer your aorta, the less coronary blood flow you will get in your coronaries. Or if you put the data in a different way, but it's from the same study, if you have a compliant aorta and you put in a stent, you see here the gain in hyperemic coronary blood flow, in blood flowing through the coronaries after a stent, if the aorta is compliant. And yes, there's a lot to gain, a lot to win here in this situation. On the other hand, if you have a stiff aorta and you put in a stent, well, yes, of course, the coronary blood flow will increase, but to a much smaller amount because the aorta is stiff. And of course, these patients still may remain symptomatic, even after successful stenting. That's another study showing basically the same thing. These were patients with coronary artery disease, 1, 2, 3 vessel disease. They were put on a treadmill exercise test, as you see here, and the outcome was the ischemic threshold, so the time to reach a certain amount of ST segment depression, depicted here. And this time was inversely related to aortic stiffness, again, and also to the amount of wave reflection, which means if you have a stiff aorta, or if you have more wave reflection, which is closely associated, you will reach the ischemic threshold earlier. And finally, this also has prognostic value. This again from our lab, more than 1,000 patients undergoing coronary angio for suspected coronary artery disease, followed roughly 5 years or so. And you see the independent predictors of the combined endpoint cardiovascular event plus mortality. Well, of course, the amount of coronary atherosclerosis plays a role, systolic function plays a role, diabetes, smoking play a role, but also on top of this and independent from this, aortic stiffness plays a role. So the stiffer the aorta, the more impairment of prognosis you will find. Okay, but then what's the relationship between arterial stiffness and the metabolic syndrome? Well, it's first of all, start with the more obvious thing. You would, of course, expect if you have a metabolic syndrome, your arteries will be stiffer. And this is absolutely true. In cross-sectional studies, here's a huge meta-analysis. So, and the mean difference between having a metabolic syndrome and not is 0.7 meter per second carotid femoral pulse wave velocity. So yes, it's clear. If you have metabolic syndrome, this will stiffen your arteries, that's clear. And the more compounds of metabolic syndrome you do have, the stiffer your arteries will be. That's the more traditional thinking. And of course, this is true and you would have expected this. But now look, that's a quite interesting study. It's a novel way of thinking. That's a longitudinal study. That's the A1 longitudinal study of parents and children in the UK, and they investigated the effect of arterial stiffness on insulin resistance. So almost 4,000 individuals. They were teenagers or young adults, 70, almost 18 years old participants from that study, and the follow-up was 7 years. So there were 2 measurements of carotid femoral pulse width velocity at 18 and 24 years, and the same 2 measurements at the same time points, measurements of insulin resistance were performed. And this is one part of the results. Your carotid femoral pulse width velocities at 18 years, of course, predicts pulse width velocities 7 years later. This is expected. Your insulin resistance at 18 years predicts your insulin resistance 7 years later. This is also predicted. This is also expected, I would say. But then look, the carotid femoral pulse width velocities at 18 years predicts your insulin resistance 7 years later, but insulin resistance at 18 years does not predict carotid femoral pulse width velocities 7 years later. So that's what you expect does not happen, but what you don't expect happens. So put in other words, if you use this complex statistical modeling, you will find, that's the summary here in the paper, adolescent arterial stiffness may be a precursor of insulin resistance in young adulthood rather than a consequence. Or put in other words, the temporal path analysis in the study suggests that arterial stiffness in adolescents may be a novel causal risk factor for insulin resistance, not the other way around. So arterial stiffness comes first. And very interestingly, importantly, the same has been confirmed in another study. That's a study from China with 14,000 participants. They were older, 48 years, free from diabetes and CV disease at baseline, the Kaluan study. And they measured here fasting blood glucose, not insulin resistance, but fasting blood glucose, and brachial ankle pulse width velocities. Follow-up was here 4 years. And what came out is that arterial stiffness was associated with a higher risk of incident diabetes, independent of traditional risk factors, or put in other words, stiffness predicted fasting blood glucose 4 years later, but again, fasting glucose did not predict arterial stiffness 4 years later. Okay, so how can this happen? Well, there is a possibility because it must be related, of course, to perfusion. So if you're young, if you have a compliant aorta, you do have pulsatile flow. That's here in the left ventricle, of course, in the aorta, of course, this is clear. But then one of the functions of the arterial system is, of course, to dampen out this flow and to have a laminar flow in your small arteries and your capillaries. That's what should be normal. But if you have a stiff aorta, if you're getting older, you see the pulsatility is increased. Here, the amplitude, blood pressure amplitude is increased. And if you have stiff arteries, they cannot dampen out these pulsations, and you may remain with pulsatile blood flow in your smallest arterioles and capillaries. It's not laminar anymore, it's pulsatile. And this may be detrimental. And there are several organs why this might happen. And it's a nice editorial from Julio Quirinos to the Chinese study, and it may be that it may be related to the amount of blood flow you do have here, for instance, in your pancreas. The more blood flow you do have, and the same, of course, is true for your kidneys. The more blood flow you do have, the more pulsatile blood flow you will get with stiffened arteries, and this may be detrimental in the end. So indeed, it may be a true finding that arterial stiffness precedes or even causes impaired glucose tolerance. So, but let's go again back to some more practical issues. Let's go back to our patients. Well, he's so far, he doesn't have severe coronary artery disease, no clinical events, which means it's a primary prevention patient. And if we want to risk stratify, then we have the new ESC guidelines on prevention. We have this score 2 and the score 2 in older people, but of course, in our patients, that's the score 2. So that's our patient is a man, he's a smoker, His non-HDL cholesterol is around here. His age is here, and that's his blood pressure. So it's what you see here. You find out even from the risk factors that this is a high-risk patient. In patients under 50, if you have a 10-year risk of fatal or non-fatal cardiovascular events, then you are actually a high-risk patient, depicted here and depicted here also by the dark red color. Okay, then shall we treat him by guidelines? The first, in apparently healthy persons, so which means primary prevention, stop smoking. Okay, that's a major point. Lifestyle recommendation. Okay, that's important. And blood pressure below 160, that's for sure. The age below 50 years, if you go down, that's the risk. It's between 7 and 8. So let's say we put him here. Then his systolic blood pressure should be between 130 and 140, and his LDL cholesterol between 100 milligram per deciliter. That's fine. That's, of course, a useful goal. But then there's a possible step 2. There's an intensified treatment recommendation based on 10-year risk, score 2, but also on comorbidities. And you can put, I think you can put safely at increased arterial stiffness here, or premature coronary atherosclerosis, but also patient preferences. The adherence was not that good. So ideally, the goal would be to have systolic blood pressure below 130, and of course, a very low LDL cholesterol. And of course, the patient need to stop smoking. So what did we do? This was our recommendation. We put him on combo therapy, of course, as now in the guidelines, ramipril hydrochlorothiazide to start with in this dosage. And we plan to increase this to a triple therapy if the goal is not reached, but we're pretty sure that this will happen. And we also put him on a high intensity statin with this goal, and we also put him on aspirin. And of course, we reinforced that the patient for sure should stop smoking. So I hope you find this even a little bit interesting, and thank you very much for your attention.